Good afternoon, my dear professors and colleagues. It's my pleasure to present today in the pediatric cataract course. So, we all know that the most common cause of treatable blindness in children is bilateral congenital cataracts, and the most common complication after pediatric cataract surgery is posterior capsular opacification. The rate of PCO is up to 100% when the posterior capsule remains intact, so management of the posterior capsule in pediatric cataract surgery is considered one of the most common challenges. And primary posterior capsulotomy with anterior vitrectomy is an essential step that can be done using the limbal approach or the pars plicata approach. However, surgeons are faced with many questions regarding which approach is more preferable. Today, I'm going to talk about the primary posterior capsulorhexis and anterior vitrectomy through the limbal approach. Regarding the advantages of this technique, that this posterior capsulorhexis is smooth, round, and offers resistance to capsular tearing. Also, it can be performed before or after posterior chamber IOL in the bag implantation. It avoids doing a sclerotomy incision with all its risks of vitreous incarceration and ciliocroidal detachment. And most anti-segment surgeons can be accustomed to this approach rather than the pars plicata approach. On the other hand, the disadvantages of this technique is that performing posterior capsulorhexis is technically difficult in a highly elastic capsule with a high tendency for extension. It needs more experience and a long learning curve, with risk of anterior vitreous phase disturbance and vitreous wick, difficult IOL implantation in a non-intact capsule with anti-segment manipulations. Regarding the technique, after finishing the IE of cataract, we inject OVD just to flatten the posterior capsule without overfilling the bag. Then we go with the tip of cystotome, find the posterior capsule, elevating it anteriorly to cause tinting, then cause a triangular tear, then go through tear to inject dispersive OVD to disperse the vitreous away from the posterior capsule so that the posterior capsulorhexis become easier. Then we go with the microaxis forceps to hold the edge of the tear and do the posterior capsulorhexis parallel with the anterior capsulorhexis, aiming to be around 4 mm in size. We grasp and leave, pulling towards the center to preventing its extension. Then after finishing the posterior axis, if we intend to implant the IOL, we should inflate the bag properly with OVD, and we can do the anterior vitrectomy either before the IOL implantation or after IOL implantation as shown in this video. We go with the foldable 1-piece or 3-piece IOL, injecting the leading haptic just beneath the anterior capsulorhexis so that it can slide easily in bag without any risk of vitreous wick. And then we go from behind the IOL to do the anterior vitrectomy. So we should know that adequate anterior vitrectomy is a must if the child is less than 5 years old. Posterior capsulorhexis should be 4 mm in size. If it's very small, it will cause capsular phimosis. If it's very large, it will make implantation very difficult. When you go with the cystotome, you should pull the cystotome anteriorly towards the back of the cornea. Don't dip it down so that you can cause the tinting of the posterior capsule and do the tear. When you go to inject inside the burger space, you should be outside anterior to the tear and then inject. Don't dip with the visco into the vitreous space, and you should see this beautiful ring. That means that you disperse the vitreous properly from the posterior capsule. You can do the posterior capsulorhexis clockwise or anti-clockwise according to your preference. When you go with the vitrectomy, you should go first with dry vitrectomy and then you go with the hydration cannula in order not to overhydrate the vitreous and prolapse it into the anterior chamber. Don't use triamcinolone during anterior vitrectomy. You don't need it. if you inject the leading haptic just underneath the anterior capsulorhexis, it will go easily in back without any risk of vitreous fall, and it will unfold easily without any complications. Many studies try to compare between limbal and pars plicator techniques in doing posterior capsulotomy and anterior vitrectomy, and we have done a study in our pediatric ophthalmology department to compare between both techniques on 57 eyes of 1 to 5 years old with a follow-up period of 6 months. And we have found that the incidence of intraoperative complications was significantly higher in the limbal group due to improper size or shape of posterior capsulorhexis and due to IOL implantation-related complications. Also, the incidence of early post-operative complication was higher in the limbal group, and most of late post-operative complication was significantly higher in the limbal group, like visual axis opacification, IOL pigmented deposits, and regarding IOL position, 100% of eyes in the pars plicator group had a stable IOL in bag. On the other side, only 53% of eyes in the limbal had a stable IOL in bag. The others were either in sulcus, tilted sulcus bag, decentered in bag, or captured in pupil. So we concluded from this study that the limbal approach had a longer operative time, more intraoperative and post-operative complication than the pars plicator approach. And thank you very much.